Hi there, thanks for coming back to another lecture. Today we're going to be focusing on chapter 12, which is prenatal care and preconception care and taking care of women during that antepartum period. Okay, let's get started. So here we are, like I said, chapter 12, and we're going to be talking for just a minute about preconception care. Ideally, and this it obviously isn't always possible, but ideally when a woman and her partner are planning a family, she would hopefully start looking at getting some preconception care. So looking at some of the behavioral tools and things that she is currently doing. So for instance, smoking, if she is, if we could mitigate some of that and change some of that before she becomes pregnant, hopefully we can avoid some of those high risk situations. Fun fact, most women do not do anything other than a required physical for their jobs unless they're ill. So they don't have preventative medical care until they become pregnant. So being pregnant is the first time they're actually in a medical establishment for care. And that can be very frightening and intimidating to some women. Some of the risk factors that are going to potentially affect our pregnancy outcome are certain medications, Accutane being one, category X. And we know that the use of this medication in pregnancy does cause birth defects, genetic defects to the developing fetus. Alcohol misuse. I know there's a lot of information out there on the internet about alcohol use during pregnancy, and we've gone through different periods in our history of recommending it, a little bit okay, some is not okay, and the current recommendation is there is no safe known amount of alcohol during pregnancy, and the research is out there, and I'll be happy to provide that if someone is looking for it. But if you do a simple Google search, you'll find that yourself. Some anti-epileptic drugs also are known to cause genetic defects, and so we want to help them manage their epilepsy, because people that have epilepsy can also have babies. If she has diabetes preconception, that's definitely a condition that we want to be aware of and help her manage as best as possible. A folic acid deficiency that can cause neural tube defects in the developing fetus. If she currently has HIV or AIDS diagnosis, we want to be aware of that and get the preventative strategies, medications on board as soon as possible. And then obesity as one of our biggest issues in pregnancy. So much so that I put it here twice. Other conditions that might affect the pregnancy, hypothyroidism before she becomes pregnant. If a patient has hypothyroidism and continues after pregnancy, she's going to need to be followed pretty closely by a lactation consultant, because some of the decrease in thyroid hormone may affect her milk production. Looking at her rubella status, if she is not rubella immune, we are going to give her some very specific education about making sure that she stays safe away from anyone that could potentially have a rubella infection. Sexually transmitted infections, I'm going to spend some time talking about those at the end of this presentation. They're not necessarily in this chapter in the way the book is organized, but it seems like it fits really well here. And then smoking. So the greatest time of risk to the developing embryo is those early stages, those early days when those tubes are starting to fold on into each other and the cells are starting to differentiate and move to their location. So 17 to 56 days after conception. And so here we are, barely missing a period at about the 40th, 50th day after conception. So that might be right. I'd have to actually research that a little bit to think about it. So most people have egg released 14 days into their cycle. So let's say 14 to 20 days is really when they're going to miss that first period. Nevertheless, early on in the development is when they're most vulnerable. So if we can mitigate some of the potential hazards like exposure to alcohol, street drugs, that sort of thing, known carcinogens, then hopefully we can not interfere with the fetal development or embryonic development. So the goal of our first prenatal visit, like I said, a lot of people don't come to the doctor on a regular basis. They aren't getting well checkups. They only go when they need them. So the goal is really to start that establishing that trusting relationship, because if we can develop that, then hopefully they will come back for all of their well visits, their well pregnancy visits, and we can find and watch for those signs and symptoms that are not good, that are leading to other diagnoses and other conditions, and hopefully prevent them. We want to get a comprehensive health history at this point. We're going to do a comprehensive physical exam, and then we're going to do a list of laboratory tests. Now, my students, my live students, are given a list of laboratory tests, our prenatal labs. You need to know these. Anyone that's going to be taking the NCLEX needs to be well versed in these labs and what they're for and what we do if the results are not what we expect. So NCLEX loves to ask questions about these prenatal labs, but also as you're caring for your moms, as you're caring for your patients as labor and delivery nurses, you need to be able to go back and look at those labs and review them one more time when you're caring for them. So when we're looking for our health history, why is she coming? She's suspicious of pregnancy. Okay, when was her last menstrual period? What are the signs and symptoms? And then we're either going to do a urine or a blood test for HCG, human chorionic gonadotropin. We're going to be looking at her medical, surgical, and personal history, and then her reproductive history. It's important to know what runs in her family, what her experiences have been, and if she has any issues. So for instance, if she's had any surgeries on her uterus, that could affect the delivery outcome for this baby. So we want to ask her all of these questions and get a very comprehensive history on her first visit. We want to know a little bit about her menstrual cycle. This is important information because it kind of gives us just some tools to start looking at when we're guessing our due date, and I'll get into that in just a minute. We also want to know the types of contraception that have worked for her in the past, because that'll be a discussion that we will be having after this baby is born. So one of the ways that we determine, anyone can use this method to determine when the due month is. I hate to say due date because it's never perfect. In fact, very few women actually deliver on their due date. It's really a guess. And if you really want to dive into this a little bit, depending on the time of year that a woman conceives will influence how long her pregnancy actually lasts. Her genetic background will make a difference on how long her pregnancy lasts. There's lots of things that are that influence us. And so we do have an average amount of time that babies need to stay in the womb. We know that, but some babies take longer and some babies don't take as long. And so when we're looking at due dates, we can't get caught up in that actual date. So one of the ways to determine an approximation of when this baby is going to be born is what they call Naegele's rule. And this is when you use the first day of the last menstrual period. You can see it there on the screen. You subtract 3 months from that, you add 7 days, and then you add 1 year, and you're going to get an estimated date of birth. Estimated. It can be 2 weeks on either side of that. Early ultrasound is the best method for dating a pregnancy because it's the most accurate. Early in the development, all fetuses have about the same measurements. And so we can predict how old this fetus is based on looking at those measurements. As we get further along into the pregnancy, we can't predict as well because then genetics start playing a part and environments start playing a part and change how the size of these babies, because some babies are born at 5 pounds and some babies are born at 11 pounds and everything in between, and some less than that and some more than that. So early ultrasound is the best method for dating a pregnancy. But if you're working in an ER or working somewhere and you need a quick estimate, this is a down and dirty rule. This is a famous NCLEX question. They love to ask you this one. Modern day, we're going to use something that looks like this, called a pregnancy wheel. And so what you would do is you would ask the woman the first day of her last menstrual period, and this white section turns. So this will go to the last menstrual period. Let's say it was October 1st. And then if you hold that and then come over here to where the 40th week is, you can predict that she's going to deliver sometime in early July or late June. Early to mid-July, late June. So this gives you an estimate. This also tells you, so let's say that the day that we're doing this is March 25th. So here again, I ask her the first day of her last menstrual period, and then I look over here to March 25th, and I can see that she is about 25 weeks on this date. And so it gives me an idea of assessing where she is in her pregnancy. The other thing you can utilize is there's a ton of apps that will do a due date calculator, again, where you use the first day of that last menstrual period. And if somebody doesn't know that, we ask them to estimate your first day of your last menstrual period. And many people keep it on an app and they have pretty accurate records. So some of the other terms that we're going to start using is Gravida and Pera. Gravida is describing how many pregnancies she's had, and Pera is how many offspring she has produced after the 20th week of gestation. So Gravida Pera is, we also sometimes call it G's and P's, and that's a common term that we use when we're giving information to each other. She's a Gravida 1, Pera 0, so she's pregnant with her first baby, or she's a Gravida 5, Pera 2, so she's been pregnant 5 times and she's delivered 2 babies after the 20th week. So this gives us an idea that we might need to do more investigation, and we'll talk more about that in just a second as we can break this down. But sometimes you'll also hear us use, we have a lot of slang terminology, but you'll hear us use the term primey or primip, and these are based on these words, primipara, meaning she's giving birth 1 time after her pregnancy. So this means this is the first time she's having a baby, first time she's delivering a baby. A multip or a multipara is somebody who has had 2 or more pregnancies. Nullipara, no viable offspring. And then we have something called a grand multip, which is where she's had 5 or more. And all of these give us clues as to what kind of care she could potentially need. So if we want to break that down a little bit further, we go into the GTPAL system. And this is when we are actually writing down the result of all of the pregnancies, and if they were term, if they were preterm, if she had an abortion, and how many living children she has. Now, just a note here on the term abortion, that is the medical term for any pregnancy that does not continue or that ends before the 20th week, or what we call viability. So abortion can be a therapeutic abortion, where that is a choice, a woman chooses to end that pregnancy, or it can be a spontaneous abortion where it ends on its own and there was no choice involved. Oftentimes, the spontaneous abortion is referred to as a miscarriage in lay terms. And I never use the term abortion to a mom when I'm talking about miscarriage or spontaneous abortion, because they only hear that hot topic word and think there's only one kind. They don't understand that's just the medical term for the pregnancy that ends. So be careful in the choice of words that you use with your patients. So looking back at this GTPAL, so here it is broken down. And so if I have a Gravida 3, Pera 2, this mom has preterm 0, abortion 0, and living 2. So she's been pregnant 3 times. She's delivered 2 babies. 0 of them were preterm. 0 abortions happened in her pregnancy history, and she has 2 living children. So where's that other baby? She's been pregnant 3 times. Well, she's still pregnant with it. And once she delivers, then that number will be added over here. As we're going through the physical examination, it's similar to a physical examination that you would do on a non-pregnant person, so an adult assessment, looking at those vital signs, making sure that we get good, accurate vital signs. When you sit a patient down to do her blood pressure, you want to make sure that she's sitting there resting for a minute before you actually do the blood pressure assessment. Her feet aren't crossed, she's not talking, you're using the appropriate size cuff. These are really important tools, and sometimes, especially if you have someone to help you, like an assistant or a CNA or medical assistant, that's taking some of this data collection, we forget that this is a very important assessment tool and we need to do it appropriately. So you want to make sure that whoever's helping you has been educated well in how to get a good vital sign. We also are going to be looking at temperature, respiratory rate, O2 sat, all those assessment tools, and then we'll do a full head-to-toe assessment. And fundal height is one of the things that we will start doing as she continues on in her pregnancy. We won't necessarily do this on the first assessment, but this is just a picture of how the fundus, which is the top of the uterus, will grow with the weeks of gestation. So if she comes in and she's not newly pregnant, she's maybe moving into the second trimester, and you do an assessment and you find that fundus, the uterus, is starting to move outside of the pelvis, then we know that that pregnancy is much further along. We can do an ultrasound at that time and try to determine, but remember I said early ultrasound in that first trimester is the most accurate. By the time we get to the second trimester, it's not nearly as accurate anymore. A fundal assessment is a tool that we're going to use because the amount of weeks of gestation, the amount of weeks that fetus has been growing, should about match the level of measurement in centimeters. And I'll talk more about that in just a second. So this is actually how we measure the fundus. We go from the top of the pubis symphysis, which is the top of that pubic bone, and we measure all the way to the top of the fundus in centimeters, and that should approximate the number of weeks of gestation. So for instance, this baby, it looks like it's a pretty big baby and that fundus is pretty large. I'm expecting that this is going to be 36, maybe 37-ish weeks. And that should be about where that measurement is. And they can be off by plus or minus 2 centimeters. We also are going to do a pelvic examination. Now, the textbook talks a lot about the different ways that we can measure what type of pelvis a woman has. Most of those are not really utilized in our modern day practice, and there's not a lot of evidence to support that they really have a lot of value. So there are 4 different types of pelvises. You can see that they have different shapes. The one that we prefer is the gynecoid pelvis, because that's the one that is most easily, the baby is most easily able to fit through this shape of pelvis. You see some of these pelvises look like they would be much harder for a baby to fit through, and it's true. Doesn't mean that you can't have a baby if you have this different shaped pelvis. It just might contribute to longer labor, longer pushing stage, that sort of thing. So there's different types of examinations that can happen. Again, most of the time, we're looking from the top view down, but if you're doing an exam, we're looking for these, what we call, markers, landmarks, looking to determine if we can feel the ischial spines of that pelvis through the vaginal walls. And that gives us an idea of what shape that pelvis is. It's not tried and true, and of course it depends on the experience of the provider. But knowing that this is the type of pelvis that we would like to have, gynecoid is the desired one. Interestingly enough, some of these pelvises can be shaped and formed with different activities as a young girl. So for instance, I worked with a provider that had done his own informal research about ballerinas and horseback riders and yoga teachers that have repeated, and gymnasts that have repeated stress on these bones as they're developing, and it can actually influence the shape of development. And of course, things like malnutrition and rickets and some of the other disease processes can affect that as well. Here we are to our prenatal labs. All of these are going to be done initially, early on, with our first encounter. And this is the information that moms need to have with them. They need to be able to get a copy of this and tuck it in their purse or their pocket and take it to all their visits. If they're going out of town, they need a copy of their prenatal labs because they're not always easy to get after the fact. And if she ends up, let's say, for instance, she ends up out of town needing care, we need to know this information, especially if she's going to deliver. So we're going to be looking at lots of things. And as we go through this course, you'll understand what all of these things are. I'm going to encourage you, spend some time this week learning your prenatal labs, spend some time reading the document that you've been provided, and we will discuss more about this in our clinic time. When you're looking at a urinalysis, I want you to know there's a lot of information we can determine when we have a urinalysis from a patient. We're actually looking at all of these different things. Most of the time, you'll be sending these UAs to labs and they're done in a laboratory situation, but there may still be situations in clinics and other places that you would be doing this yourself. And so the idea is you dip the urine here, you let this sit for a period of time. Each of these have a different period of time that they need to sit. So usually about 2 minutes. And then you're going to compare the marks on this stick to your normal values. So for instance, you can see your normal values are all along this side, and then you may have different levels here. If you have glucose in the urine, it's going to show here. If you're spilling ketones, it's going to show here. How well hydrated someone is, if there's blood in the urine, what the pH is, if there's protein, super important, you'll understand more later, if those white blood cells, leukocytes, and if there's nitrates, which tells us if there are specific infections. So understanding a UA, I know this is repeat information, this, you've all learned this before. I want you to spend some time making sure you actually understand it. And then our follow-up schedule is going to be every 4 weeks, up to the 28th week, every 2 weeks from that point forward, and then every week from about 37 weeks on. Now, of course, this is in a low-risk mom. In a high-risk mom, we're going to be doing it more often. So again, every time they come into the doctor's office for their prenatal visits, they're going to be looking at weight, they're going to be looking at blood pressure and comparing it to the baseline values that you took at the initial prenatal visit. We're going to be testing the urine for protein, glucose, ketones, and nitrates. We're going to be doing that fundal assessment, as mentioned, asking her about fetal movement, listening to the fetal heart rate, and teaching her about danger signs. We need to cover this every time we see a patient. We need to make sure she understands what needs to be reported. These are the warning signs in pregnancy. By the time we get done with this course, you'll know exactly what all of these mean. For now, I want you to just focus on what they are. Visual disturbances, seeing spots, feeling like you're going to pass out, losing your peripheral vision. That's what we consider visual disturbances. Headaches, especially frontal headaches that don't go away with Tylenol. Extreme edema, especially around the face or around the eyes, called periorbital edema. Rapid weight gain, more than 5 pounds in a week, it's most likely edema. Extreme pain from anywhere. That could be epigastric pain. That could be flank pain. That could be contraction pain. Anything that is continuous needs to be evaluated. Signs of infection, which include rapid heart rate, temperature over 100.4. Any vaginal bleeding or drainage needs to be assessed. Any persistent vomiting, meaning they can't hold anything down. Having muscular irritability or any sort of convulsion. and the absence or decrease in fetal movement once it's been felt. That's probably the most important thing. I'm not going to go too deep into this in this lecture, but when a fetus is stressed, the first thing it's going to do is slow down all of its major muscle movement to conserve energy. So that's often our earliest sign of distress. Some of the diagnostic testing that we can do, all of these are not done frequently, but I'm just going to mention a few of them here. In our local area, there are a few that we don't do at all. They have to be sent out to a larger tertiary center to do it. But amniocentesis, biophysical profile, chorionic villi sampling called CVS, and perinatal education. We'll talk about all of these. So when we're doing amniocentesis, this is when they actually go in using an ultrasound, making sure that they don't hit the placenta or hit the fetus, and insert a needle and pull some of this amniotic fluid out and test it. This is not a test that they would do unless there was a screening test that warranted it. So often they will do some of our early quad screening markers looking for genetic variations. And if one of those screening tests are positive, then they would go the next step and actually do a genetic sequence of that fetus. And they can do that by getting the cells that are in the amniotic fluid. Now, there is risk of infection. There is risk of miscarriage after this procedure, preterm delivery. And so, of course, when a woman is being given this option, she is going to be given benefit, risk, and alternative to the procedure. And most often women, well, I won't say most often, but sometimes women choose to do this because they want to know and not be surprised when the baby's born, or other women choose to do this testing to confirm diagnosis and then have the option of ending the pregnancy. So the alpha fetoprotein test and our quad marker screening tests are blood tests that are done early. And if those are positive, then we might move into amniocentesis. And we also have ultrasound. They typically do an ultrasound about the 20th week to, they call it the anatomy screen, make sure all the parts and pieces are forming and are present. And then sometimes they'll do ultrasound later on looking at fetal well-being. Some of the other things that are done, this PUBS, percutaneous umbilical blood sampling, you can read about that in your book, and the CVS, you can read about that in your text as well. They aren't used here locally, but I know some of my online students may have these in their areas, so you might want to take a look at those. We also have these three tests. They really go together: non-stress test, contraction stress test, and biophysical profile. Interestingly enough, contraction stress test is still taught and talked about quite a bit, but in my 20+ year career, I have done exactly one of these. So it is a not very common practice. It's usually a provider that was trained many moons ago that asked for this. So a non-stress test is using the fetal monitor to determine some specific markers that are going on with the baby to see if they are tolerating what's happening in the uterus. A contraction stress test is actually causing contractions to happen and see how well the baby tolerates that. And that a biophysical profile is often done after a non-stress test that was not reactive. So then we go a little bit further and we do an ultrasound with some further criteria to determine how well the baby is tolerating being on the inside. And what that means is, how well is the baby oxygenated? And is it a potential that the baby would be better off outside versus inside? And again, we're going to talk more about this when we do our labor section next week. You want to start spending some time understanding fetal monitoring. Leopold's maneuver is not something that you as students will get proficient at, but I want you to know what it is that we're doing when we're trying to determine the position of the baby by feeling it in the womb. This takes time, it takes practice. Certainly, if you're putting the patient on a fetal monitor, try to figure out what feels like head, what feels like bum, what feels like the bony, pokey parts of the knees and arms and legs. You can ask mom, where do you feel your kicks? And that's one of the things that we'll do, is ask her where she's feeling her movement to help us determine where the baby is. I'm going to go back to that for just a minute. So if you were putting the fetal monitor on here, you want to try to go right against that baby's back, because it kind of looks through, and then it's going to give you a good contact, and you'll get to hear the fetal heart rate very well. Ultrasound, there's lots of different tools that we use in ultrasound, and then we even have our 4D ultrasound where you can pretty much tell everything about this baby. It's certainly different than what you see here. This is an additional specialty, additional certification that some nurses, labor and delivery nurses, choose to get. And I know some midwives also choose to get extra training in ultrasonography. This is that non-stress test that I was talking about. This is putting the mom on the electronic fetal monitor. The bottom one down here is going to be catching the baby's heart rate. The top one up here is going to be resting on the fundus of the uterus to determine movement, so contractions. That's called a tokometer, and this is an ultrasound. So we use the abbreviation TOCO and ultrasound, and what prints out on this paper is what's happening in the uterus and then what's happening for the fetal heart rate. And I have an entire separate video about looking at fetal heart rate and what it is. This is an additional certification that all labor and delivery nurses are required to have. I say all, they all should be. Most facilities require it as part of your job. But there's an entire separate video, and I recommend that you watch that if you have not already. And for my live students, it is part of your curriculum to watch it. The biophysical profile is one step further, where now you're going to do the fetal monitoring and add in an ultrasound looking for these specific things, looking for fetal breathing movement, fetal tone, how flexed or flaccid the baby is, and looking at amniotic fluid. So if you are doing a biophysical profile, you're going to get a score based on these things, and the scoring system will help the provider and the mom determine, is this baby most likely tolerating what's happening in the uterus, or would it potentially be better off, read more oxygenated if we get this baby out, or help this baby to come. Okay, so now we're going to talk a little bit about the common discomforts of pregnancy. Here we see our first trimester discomforts. And remember, I said the warning sign, for instance, with nausea, vomiting, it's common. It's normal to have some nausea, vomiting, but if you can't hold anything down, then we've moved into persistent vomiting, and that needs to be looked at. So you have to know what's normal in order to know what's not normal. So all of these things are normal, and moms need to be educated that these are to be expected. And there's different tools and education techniques that we can give them to help them deal with some of these discomforts. Second trimester, you start to see varicosities, sometimes increased backache, hemorrhoids, increased bloating and flatulence, and that's because this baby's starting to grow and press up against the bowel. So this picture is showing you from second trimester on, we really don't ever want this mom to lie flat on her back, because she can get what's called in vena cava syndrome, where the pressure of the fetus actually cuts off the blood flow to her inferior vena cava. And if that happens, she's going to feel lightheaded. She's going to eventually pass out. And if mom passes out, baby doesn't get blood flow either. So it's important to encourage moms never to lay flat on their back, even for different procedures and things that we're asking her to do. If you just tuck a pillow up underneath her hips, it will take the pressure off. But most women have an instinct that they don't want to lay on their back, and encourage them to sleep on their side. And there's the slide about the vena cava syndrome, or supine hypotension. And then third trimester, so this would be a good way to support a mom that has a very gravid uterus. In the third trimester, she's going to see the return of some of those first trimester discomforts. She's going to see increased shortness of breath and maybe even some dyspnea. increased heartburn, indigestion, dependent edema. We talked about why that is common in pregnancy. And she'll start experiencing some Braxton Hicks contractions. Fun fact, she's been having contractions all along. Her uterus has been practicing and having them, but because the uterus was small and because her hormone levels hadn't gotten to the point where the uterus is super sensitive to those hormone levels, she maybe didn't feel them yet. But most pregnancies have Braxton Hicks contractions from the second trimester on. They just aren't as apparent. They just aren't as recognized as they are when they get closer to delivery. So the other things we want to promote when we're promoting self-care, I've already talked in previous lectures about not getting in saunas and hot tubs, making sure that she maintains good personal hygiene, hand washing, hand washing, hand washing. Pregnant women are more susceptible to infection because their immune systems have to be dampened just a little bit so that they don't fight off this little fetus that is now growing inside them. So pregnant women are at high risk for infection. Dental care, very important that she maintains good dental care. Ideally, this is before she gets pregnant, but afterwards, there have been some studies that link some gingivitis and some dental caries and issues to preterm delivery. Making sure that she's wearing appropriate clothing that's not restricting the growth of this fetus. Travel. I mention travel here because as they are more susceptible to infection, traveling especially to other countries, she is at higher risk for catching some of those infections that we see. Now, ZIKA actually is everywhere. It's mosquito-borne infection, but we do want her to be aware that, you know, as a pregnant woman, she is at higher risk. And then talking about immunizations, I'm going to spend the next couple of slides talking about these. There's a couple of them that we want her to have in pregnancy, some for her protection and some for the baby's protection. And I'll talk more about that in just a minute. Ideally, we would like her to have some sort of perinatal education, talking about childbirth. These are just the 3 different methods. I mentioned these in my one of my previous lectures, how these started coming about. These happened in the 50s when women really started taking back childbirth and weren't just accepting of everything that was offered to them. And so these are just the different theories that are out there. Lamaze, Bradley, Dick Reed. If you're interested in the history of childbirth, spend some time looking at them. Some of the newer ones that are extremely effective is hypnobirthing and self-hypnobirthing and meditation. And these many women find very effective in helping them manage the pain of labor. Now, if you're planning on having an epidural, it doesn't mean that you still shouldn't go to some sort of education classes, because they talk about lots of different things in our childbirth preparation and childbirth education courses other than pain relief. It's not just how to deal with contractions. Now, it kind of has that idea because that back in the old days when we were just teaching Lamaze, that's all we really talked about, is how to deal with labor. But now they talk about the process of labor, knowing what's normal, what's not normal. Sometimes they mention some of the interventions that might be proposed. They talk about new baby care, what to expect postpartum in caring for themselves, feeding methods. Lots of information is presented at a childbirth education course. I always like to use this analogy. Think back to when you learned how to drive. How much time did you have to spend in a classroom learning about the rules of the road and the different tools that you're going to use when you're driving? And then how much time did you spend with somebody that knew what they were doing behind the wheel before they let you have a driver's license? Well, it's the same idea here. You really need, as a mom, you're going to build community, and you really need some time with someone that has some experience in these areas. You can't be expected to know everything the minute that baby is born. So I recommend childbirth ed. Here are some of the other topics that are covered in childbirth education courses. And again, highly recommended. Unfortunately, in this day and age, we don't see a lot of participation. What really needs to happen, in my opinion, is we need to modernize these get some great courses online, which there are some online, and start encouraging women to attend and make it, you know, worth their time and meeting their needs as a modern day pregnant mom. Looking at where she's going to go, all of these decisions need to be made during pregnancy, and then sometimes they might change. For instance, if she's planning on having a home birth or an out of hospital delivery, and then she moves into the high risk category, then those changes are going to have to be made to a hospital facility. Deciding if she is going to be having obstetric care and the traditional medical model, if she's going to have midwifery care and the midwifery model, if she's going to hire a doula, who is a basically a coach that's going to help her navigate what's happening before birth and then during the birth, and then a support person after. So it's like having your own specific private childbirth educator at your disposal, and they do so much more than just education. They're also support. Thinking about feeding choices, every woman needs to be told risk, benefit, and alternative of breastfeeding, and risk, benefit, and alternative of bottle feeding. And having this information before the baby's here and needs to be fed every few hours is much more useful than trying to figure all of it out once the baby's here. And then here's a slide that just talks about some of the benefits of breast milk, human milk. Okay, so let's talk a little bit about the immune system in pregnancy. This is just showing that this mom, like I said previously, she has to suppress her immune system just enough so that she doesn't immune system her baby right out of her body. And so what that means is she is now going to be more susceptible to other types of infection. We're going to be moving into looking at some of the infections that she is more susceptible to and how we can hopefully mitigate some of those. So there's going to be some pretty graphic pictures of babies that have some of these infections. And we do recommend getting vaccinated for the ones that we can get vaccinated for. So the torch panel is looking for specific infections. Sometimes you'll hear this talked about if a mom has had a miscarriage, or if she has an infection in pregnancy, or if the baby comes out with some specific physical markers that look like maybe there was an infection. They'll often do a torch panel to try to figure out which infection she actually has. So toxoplasmosis is a can't remember now if it's a bacteria or a protozoa, but it is a contaminant that is often found in cat litter or unwashed vegetables, and that come from areas like farmers markets and homegrown vegetable gardens that cats might frequent. So we're often exposed to this. Those of us that have cats, we change the litter box, but remember, as a pregnant woman, she's more susceptible to certain things. And toxoplasmosis can pass through the placenta and get to the fetus, and that's no good. So the best way is for her to avoid changing the litter box and making sure she's washing all of her vegetables. If she doesn't have the opportunity, then she could wear a mask when she's changing the litter box, and make sure that she's using good hand washing techniques. Cytomegalovirus. This is the most common virus out there. It is very hard to find an adult that has not been exposed to cytomegalovirus, but if she becomes infected with CMV during pregnancy, it can definitely affect her fetus. This is what they call the blueberry rash. It's the classic blueberry rash that we see in CMV babies. We often, these babies also often have developmental delays and are small and are born premature. So the best way to avoid any viral infection is wash your hands. Wash your hands. Try not to touch your face. Don't put your hands in your mouth. Like, wash your hands, wash your hands, wash your hands. It is one of the most effective infectious disease tools we have. Wash your hands. Don't get the virus in your body. if you can help it. This is herpes, and this is congenital HSV. So herpes is something that stays with you forever once you get it. We often refer to it as herpes 1 and herpes 2. Herpes 1 used to be thought of as just found on the face and or in the mouth, and herpes 2 was thought to be only in the genitals. But nowadays, if you were to actually do a DNA test on all the different herpes, you'd see that they're all interchanged. So you might find HSV multiple places of different varieties. So if a baby is born to a mom that has a current HSV outbreak, or if the mom has an HSV outbreak during pregnancy and it is her water's broken, and there's actually even blood transmission possible, this is what happens to these babies. Sometimes these babies won't show up with this until they're about 3 months old or so, and it often turns into herpes encephalitis, and they have a large mortality rate when they are infected with this. So what we do is, if she is HSV positive during pregnancy, we might offer her some suppressive medication. And if she's HSV positive and has a current outbreak at the time of delivery, we would offer her a cesarean section. We would highly recommend a cesarean section in order for this baby not to pass through that infection. This is congenital syphilis. Once again, if a baby is exposed to this in utero, they can get a congenital form of it. It has a very high mortality rate, and in certain areas, this is endemic, and we are testing them in our high risk areas. We're testing them in the first trimester of pregnancy, in the third trimester of pregnancy, and then once again on the day of delivery, because we want to try to treat them as soon as possible. Now, once you've been infected with syphilis, your syphilis test will always be positive. So then you would have to do a titer to determine if it's a current infection or an old infection. And this can be treated with antibiotics for both mom and baby. Zika virus, it causes severe anomalies in our babies, one of them being microcephaly. These babies will have extreme developmental delays, and it's not reversible. Zika virus can also be spread through the semen of an infected male. And so once again, we want to encourage moms, if at all possible, try to avoid places where Zika is prevalent, and making sure that they're not getting bit by mosquitoes, whatever that means, using some repellent, wearing long sleeves, not being out when they're active. It's really hard in some areas to stay away from the mosquitoes, but Zika is a very real problem in pregnancy. And then group B strep. Group B strep is a natural, normal flora that hangs out on our skin, and some women are colonized with it in their perineal area. You'll remember from previous lectures where that is. So, well, about 20, 25 years ago, we started testing women at the end of their pregnancy, about 37 weeks, and doing a swab down below on their perineal area to see if they're colonized. And if they are, we give them antibiotics in labor to try to cut down that colonization to lessen the exposure to babies. If you want to pay attention to the medications on your medication list and in the medication video, these are things that you'll need to know. So we try to get at least one dose 4 hours before baby is born, or the equivalent of 2 doses, into a mom when she is pregnant to decrease the amount of GBS exposure. So group B strep is one of those things that if we can avoid it, we try. If we can't, then we're looking for early signs of infection. Early signs of infection in a newborn are very specific, and we'll cover that more in our newborn chapter. But you can see just from looking at this full-term baby on a ventilator that it does not feel well. It's very pale. It has very poor tone. It isn't very active, might have a little sedation going on because it's obviously intubated and needing some respiratory support. So group B strep, very serious, and something that we want to take very seriously. Here are some of the risk factors for neonatal sepsis, both major and minor. We'll spend some time looking at this slide, and we're going to cover more of this when we get into problems of delivery. And here's our immunization and pregnancy recommendations. So I've given you some specific sites that you can go to. These are the ones that are recommended in pregnancy and the ones that are recommended when you're not pregnant. So we cannot give anything that is a live virus during pregnancy. So for instance, MMR cannot be given during pregnancy because it contains a live virus. We can't give specific influenza vaccines that contain live viruses. We can only give the inactivated ones. So I said previously that sometimes we give these for the mom and sometimes we give them for the baby. So we want every pregnant mom in her third trimester to have a Tdap vaccine to give some pertussis immunity, refer some pertussis immunity to this newborn. So mom may already be immune, but baby is not going to be able to have that vaccination until it's about 15 months old. So if we can give some referred immunity in those first few months, that offers a level of protection. The same with influenza. Babies are not able to have an influenza vaccine, but if we can, protect the mom, majority of patients that are hospitalized for influenza are either elderly or pregnant, and B, protect the baby, again, giving them some referred immunity, we try to do that. And with our COVID vaccine, we're seeing referred immunity for our newborns if mom is vaccinated during pregnancy. And then women who are HIV positive have special treatment. It used to be a pretty sad diagnosis for a mom to be pregnant with HIV, but nowadays, here we are 30 years later, we can, if we are able to get full treatment to these patients, that we see transmission as low as 1%. And without treatment, it's as high as 35%. So again, paying attention to your medication list, looking at the different medications that we're going to be giving both mom during pregnancy, during delivery, and the newborn are important. Okay, thanks for being so attentive. As always, reach out if you have questions or comment below if you want to continue this conversation.